invite Dr. Ronnie to talk on medical management, the newer horizons and special situations. And he has another topic, that is role of glaucoma progression detection in treatment modification. He'll be delivering both the lectures now.
Thank you, Dr. Girija. So I'm going to speak to you about a few of the newer drugs that are available to us, some that we're already using and some that are on the horizon, and also a few special situations where we have to be a little careful about medications. So we have been using Rho kinase inhibitors for about 1.5 years now, and we know that it works on the trabecular meshwork by increasing aqueous outflow. There are 2 of them available to us. I'll just briefly take you through the literature there. And one of the first studies was an open label prospective study when they used this drug in POAG, ocular hypertension, or pseudoexfoliation glaucoma. And they found it was reasonably effective as monotherapy, causing about between a 3 to 4 millimeter decrease in intraocular pressure. Keep in mind that most prostaglandins will give you about double this. And when they combined it with timolol or latanoprost, you did see an additive effect. So when you combined it with these are patients who were on timolol before instillation, you did see an additive effect of about 2 millimeters of mercury. With latanoprost, you again saw an additive effect of between 1 and 3 millimeters of intraocular pressure. So it was both as a first line and as a second line drug, it did show IOP reductions, but the first line reductions were not as high as with timolol or a prostaglandin. But what was interesting here, and this is something that most of us have seen in clinical practice, is that fairly high rates of hyperemia. So even when it's added on as a second drug, you do get significantly higher rates of hyperemia as compared to the baseline. So when you look at safety and efficacy, this is a large study of almost 3,000 patients, people with POAG, NTG, secondary glaucomas, and everything else. And when you look at this, you find that in almost all the types of glaucoma, whether it's ocular hypertension, POAG, NTG, PSC, or secondary glaucomas, you did get intraocular pressure reductions, and they were consistent. And this reduction was actually linked to the degree of pressure. So the higher the pressure, the greater the reduction you got. In the NTG spectrum, you found relatively low reductions in intraocular pressure. This is expected because when it works on the trabecular meshwork, it is limited by the epithelial venous pressure, and you're really not going to get much lower than that. Again, when you look at the 18% had adverse drug reactions, conjunctival hyperemia was the commonest one, but most of us feel that the actual rates are probably a little higher than 18%. What about netasertol? So netasertol, in addition to this, also is a norepinephrine transporter inhibitor, and therefore it inhibits aqueous humor production in addition to enhancing trabecular meshwork outflow. So the ROCKET trial was a phase 3 clinical trial which looked at netasertol to timolol, and they looked at people with pressures of between 20 and 32 millimeters, 20 and 27 millimeters of mercury, and in ROCKET 4 between 20 and 30 millimeters of mercury. Most drug trials actually include patients till 32 millimeters of mercury, and they start at about 24. So just keep that in mind when you listen to these results. So the mean IOP reduction was reasonable, about 4 millimeters of mercury. This is a maximum baseline intraocular pressure, and with netasertol you got about 4 millimeters, with timolol you got marginally more than that. And over time also, you did not see again the same effect that I showed you in people with relatively low pressures. You got relatively low intraocular pressure reductions, and this IOP reduction was consistent over time. So at about week 2 you saw an effect, and after that stayed more or less consistent. So that tells you that when you start this drug, you can probably call the patient at around 2 weeks to see whether it is working optimally. Conjunctival hyperemia rates were significantly different as compared to timolol, with about hyperemia was on an average twice what you see with timolol. You also had no systemic side effects unless the heart rate differences that you saw with timolol. So this study gave us closer to the real world what we see, about 50% hyperemia instead of the 18% reported in the previous study. Now compared to latanoprost, if the baseline intraocular pressure was less than 26, it was non-inferior. If the baseline intraocular pressure was less than 30, once you included patients with little higher pressures, it failed the non-inferiority test, meaning that latanoprost was little better. And conjunctival hyperemia was almost 4 times higher than with latanoprost. What about nocturnal IOP? Because some of the drugs that we use don't really do that well at night. And what you can see here is that you do see a good reduction from the intraocular pressure. And that reduction happens both at night and during the day. But at night, because the eye pressures go up, the actual intraocular pressure levels are a little higher than what you record in the day, but proportionally, the reduction is similar. So they're a useful second-line drug in our patient. And intraocular pressure reduction is consistent over 24 hours, but keep in mind that conjunctival hyperemia is common, and the reduction is modest, which is the reason we don't consider using this as first line. So, but keep in mind that any new drug you will have new complications. This is Rho kinase-induced reticular epitheliopathy, and typically you will see it in anybody who's got a little bit of a corneal issue. Sometimes you see this sort of picture. It's reversible, it goes off once you stop it. The other drugs which you are likely to see maybe in the next 24 months definitely are the latanoprost Bunod, which is a nitric oxide donating prostaglandin F2 analog, and it targets both conventional and uveicular outflow pathways. So the LUNA study studied this with about 700 odd participants who were randomized to either latanoprost Bunod or timolol. And what you can see is, compared to timolol at all time points, at different time periods during the study, you saw significantly higher intraocular pressure reductions, which seem to increase. So you can see that the difference between timolol and latanoprost Bunod increased at 3 months. So you saw even beyond 6 weeks a further reduction in intraocular pressure as compared to timolol alone. So in the Apollo study, which was a 3-month double-blind study followed by a 9-month open-angle study, you again found hyperemia and irritation as being the commonest side effect. And the mean decrease in intraocular pressure was between 8 to 9 millimeters of mercury at 3 months, as compared to between 6.5 to 8 millimeters of mercury with timolol. So little higher intraocular pressure reductions as compared to timolol, and a fairly reasonable safety profile except for the hyperemia. This drug is the omidanapag isopropyl study. This is compared with latanoprost and POAG and ocular hypertension. This drug has been used in Japan for some time. The India phase 3 trials are over, and I'll be presenting the results next year, so I can't present the results here. But I will tell you these results from the Japanese study. And this was about 250 patients, out of which they randomized 190. And what you can see here is that compared to latanoprost, you do see somewhat similar intraocular pressure reductions. At week 4, there's a marginally maybe a 0.5 millimeter difference, where latanoprost did a little better than the omidanapag. Again, in terms of side effects, this had a little bit more hyperemia as compared to latanoprost. And the other unusual change that you see with, sorry, it's not that in the slide. One of the other unusual things that you see with this drug is some patients have an increase in corneal thickness. No impact on the intraocular pressure, but some patients have an increase in corneal thickness, no change in endothelium, nothing else, but it's there. So one of the issues is most of the previous studies that have been done on this have never looked at corneal thickness over time in the patients. So this study did, and they did pick up about a 5, 7, 8, 10 micron difference. So that's an interesting thing. We don't know why it happens, but it doesn't seem to impact your results in any way. This is the bimetoprost sustained release implant, and this is data from the phase 1, 2, 3 study. This is what it looks like. It's on an injector, which is basically similar to Ozurdex. It's a platform technology, and you can see that little thing is injected into the anterior chamber. It has been approved for use in the US, but only as a single-time injection. The effect is supposed to last for 3 to 6 months, and there are, in some of the data, they do show the effect lasting for as long as 2 years. But in general, 3 to 6 months is what you see, and you can see that the topical drug is in the green arrow, and the implant is in the blue arrows and the black arrows, and you can see that at 3 different dosages, you see not very much of difference between the two. So that's a fairly useful way of, I mean, it's something which, again, you might see coming to India in the next 36 months. The travoprost punctal plug has been also tried, and what you're seeing here is intraocular pressure reduction of about 25%. So you saw comparable intraocular pressure reductions at 1 month compared to the topical travoprost in phase 2 clinical trials. One of the concerns with all the sort of punctal plug implants is that it can cause dilatation of the punctum, and the punctum starts becoming quite ugly looking after 3-4 months. So that is something which is a bit of a concern. the two special situations that I will deal with are children and pregnancy. And the reason I'm talking about this is basically with respect to just one single drug, and that is brimonidine. So if you look at brimonidine, you have a bunch of papers in 1999, apparent CNS system depression in infants after the use of timolol, of brimonidine. So the kids became poorly responsible and lethargic. In fact, some of them went into apnea with the drug. And it's very, very clear that you should not use the drug in children. Therefore, you should not use it in neonates between the age of 2 years. Unfortunately, this continues to happen, and this is a paper published 16 years after that, when this was given to a child with congenital glaucoma who went into respiratory depression. And if you look at the literature, you have between 2007 and 2016, 6 cases reported in the literature itself. So, I mean, as ophthalmologists, this is something that we should not do. You can lose the child because of this. So if you learn, I mean, this is just one take-home message about this. Don't use brimonidine in a child below 2 years. Above that also, if you need to use it with punctal occlusion and warn the parents that this might happen. So you can possibly use beta blockers, latanoprost, dorzolamide, brimonidine, and you need to do punctal occlusion and all. Keep in mind that all the newer drugs that you're getting, we have no information in children. So coming to pregnancy, you have basically class A, B, C, D, and X, with X being unsafe at all. Class D is unsafe because there's evidence of risk in certain clinical circumstances. Class C is uncertain safety, but animal studies show an adverse effect, no human studies done. And class B is presumed safety based on animal studies. Class A is absolutely safe. In pregnancy, we have no class A, in glaucoma, we have no class A drugs. Brimonidine is the only pregnancy class B drug. Class C is everything else. Keep in mind that if you're going to use brimonidine, you have to tell the mother to stop using it the moment she starts breastfeeding because it is transmitted in milk. Prostaglandins, there's a theoretical risk that it might cause uterine contractions and influence fetal circulation, and it's suggested to avoid it in 3rd trimester. There is no evidence for this. This is something that all of us feel. If you remember our gynecology postings, we used to put huge amounts of prostaglandin ointment. I'm not sure this 0.005% will do anything, but it's something that you need to keep in mind. So thank you. And